Hello, everyone. My name is Marwa. I'm a PhD student in the Department of Family Medicine. So I'm working on patient with dementia, the quality of life, and caregivers as well, under the supervision of Dr. Isabelle Vidal. And I'm also the president of FMGSS, the Family Medicine Graduate Student Society. So before we start, I'd like to read the land acknowledgement. So McGill University is located on land which has long served as a site of meeting and exchange amongst Indigenous peoples, including Haudenosaunee and Anishinaabe nations. McGill honors, recognizes, and respects this nation as the traditional stewards of the land and waters on which we meet today. And today we have the chance to have Dr. Marie-Thérèse Lucier. Dr. Lucier is a full professor in the family medicine and emergency medicine department at Université de Montréal. Until recently, she practiced family medicine at the academic family health team in Ville de Laval, Quebec. She's the director of the RRSPUM and the Family Medicine Department PBRN since 2012. And she's a co-director of the Quebec nodes of the Canadian Primary Care Sentinel Surveillance Network since 2010. Her main research interests are chronic disease management and polypharmacy in primary care with a focus on healthcare provider-patient communication and the use of information technology. She has co-authored more than 100 papers in French and English on these subjects, and she's also co-editor on the only French language textbook on health communication, La communication professionnelle en santé, 2005 and 2016, used in many health science faculties of French-speaking countries around the world. So thank you for being here. I would also like to remind you of the title today, the Canadian Primary Care Sentinel Surveillance Network. The presentation will be 30 minutes and the Q&A session, the discussion session should be 25 minutes. The seminar is recorded, so if you don't feel comfortable with that, please turn off your video. You can also write your question in the chat or raise your hand during the Q&A at the end of the presentation. So thank you so much, Dr. Lucier, for being here today, and the floor is yours.
Okay, thank you. So I will share my screen and we'll just try to make sure that everything is working. So are you seeing the right screen, the full screen, or my presenter screen?
C'est bon.
C'est bon, très bien. So thank you very much for the invitation. Thank you, Alexandra, for inviting me. And I'm really pleased to see you all today, many of whom are my colleagues for many, many years. So I'm here today to just review what the Canadian Primary Care Sentinel Surveillance Network is all about. For some of you, this is not going to be big news. Maybe for others, there will be some learnings. So I don't see the chat right now, and I understand that the questions and comments will come at the end. I'm used to giving this chat in French. I haven't practiced it very much in English, but I'll do my best, but there might be some moments where I revert to French. So I know most of you understand French perfectly. So just to start off, I have no conflicts of interest to declare in relation to this project, the SIPSN project, or this presentation. I'd like to acknowledge our team in Quebec. So I'm a co-director now of the Quebec node of SIPSN. I share this responsibility with Professor Aude Motulski, who is a pharmacist PhD at the École de Santé Publique of Université de Montréal and Faculty of Pharmacy. We have a research coordinator, Fouad Mafi, and a data manager called Badreddine Saya. So we're a small team, but we work quite well together. So I entitled this The 5 Whys. I hope I'll answer the 5 whys and maybe give you some a little more information about those 5 whys. So who are we at SIPSN? So SIPSN is a group of 17 different PBRNs or regional networks that are distributed in 8 provinces and 1 territory. You can see from this map that there's a an overrepresentation, if I may say so, of Ontario networks. Quebec has only 1 network. We're working on a second one right now with Université Laval, but for the time being, there's 1 network. There's 1 network in the Maritimes, 1 in Terre-Neuve, and 1 in Manitoba, 2 in Alberta, and 1 in British Columbia. So these are all primary care, practice-based research networks. In terms of the national organization, this is the governance structure that we have agreed upon and has been renewed, I believe, about 2 years ago now. So the basic organization is a steering committee. We have at this moment only 1 chair, who is Dr. David Barber from Queen's University. We used to have Sabrina Wong, but Sabrina has moved on to other responsibilities, so she's no longer co-chair. So David Barber is the chair, and this steering committee involves all the different network directors that of the PBRNs that we've seen in the previous slide. So the steering committee is supported by a secretariat in which we have a data scientist, an analyst, an admin person, and a national epidemiologist. And these people are working at Queen's University. That's where the hub is. There are different working committees, research and development, and technology development and operations. Those are actually our 2 most important working committees. And as you can see, in terms of membership, well, we have a variety of persons, students, patient and caregivers, as patient partners, clinicians that are sentinels, and our researchers. So it's quite a large organization, and we have a steering committee meeting every month, so that we're keep in touch with what's going on nationally and at the different networks, so we can all learn from one another. So how about who we are, CIPSEN in Quebec? Quebec is one of the smaller networks. You all know that our cadre législatif in Quebec has not been easy for projects like CIPSEN over the last years. Things are changing rapidly right now, but this in part explains why we remain quite small. In a nutshell, we've been looking at academic family medicine teaching clinics, because most of these clinics are within our health establishments, nos établissements de santé. And in this context, with the legislation as it was until very recently, we could obtain a opt-out equivalent permission by the directeur des services professionnels to gain access to the data in the EMRs. I'll come back to the EMR data in a few minutes. So at this point in time, we have 9 active practices. Most of them are GMFU in Quebec, and about 130 sentinels that are participating in our data. Roland is on the call, Marion Dove is on the call, and we had obtained a full consent from your CIUS, I don't remember how the name is, Centre Ouest de Montréal, and for the Jewish, but as you know, our Medfar has not agreed to help us develop the extractor, so we've kind of abandoned our work with your clinics, but hoping maybe in the future that conversation can resume. So at the moment, we have 3 GMFUs in the CIS des Laurentides. We have 4 clinics in the CIS Laval. We have one of the clinics of the McGill network, which is Gatineau, but the number of physicians is decreasing at the moment in that GMFU. And we have a new GMFU from the Sherbrooke area, the Sherbrooke PBRN, Rappel. And right now we're hoping to introduce these 3 new clinics because we have developed an extractor with OmniMed. So, and these other clinics are dans les coulisses. They're waiting to see if anything's going to happen with Medphar. So it's a small contribution to SIPSN, but we've maintained it over the years, although we've met some difficulties. So so that was who we are. So what do we do? So SIPSN is the first Canadian multi-disease primary care electronic medical record surveillance and research database. It securely collects de-identified health information from EMRs of participating primary care healthcare providers, and we call these providers Sentinels. We're extracting right now from 11 distinct EMR systems used across Canada, 2 in Quebec. We have about 1,500 primary care healthcare providers. These can be family physicians or nurse practitioners from 250 practices, and there's more or less 2 million patient records in the database as of our last extraction. So it's a longitudinal database that contains de-identified data used, and it's used for what? For public health and primary care research, and also quality improvement. So SIPSN's mission is to improve primary care healthcare delivery outcomes across the country, while also facilitating innovation and excellence in primary care research. When we started SIPSN back in 2008 as a pilot project supported by the Public Health Agency of Canada, there was like a black box. We had administrative databases looking at hospitalizations and visits to emergency and some maybe in Quebec CLSC data. But what was happening in primary care physicians' offices was not available easily. So with the introduction of the EMR, it appeared to us that it was time to open that black box to support excellence in primary care research. So it brings together, as I said before, 17 practice-based or regional research networks under a common governance structure for the purposes of research, disease surveillance, and also quality improvement. So what are the SIPSN objectives? Is to create a pan-Canadian primary care database built on the data collected from the EMRs, the 11 EMRs that we're able to extract from, that are used by primary care healthcare providers who agree to participate. Most of them come from academic family medicine teaching units. The objectives is to provide Sentinels with feedback reports, presenting several statistics on the profile of their clientele, and allowing them to compare themselves with the colleagues from their practice, from the same clinic, from the same network, and also with averages from the rest of Canada. And finally, SIPSN wants to participate in improving the quality of care for Canadians with chronic physical, mental illnesses based on evidence and research. These were the original SIPSN objectives. We've moved from, we're still including for sure chronic physical and mental illnesses, but because of the nature of the data that we're extracting, we can also look at more acute physical conditions right now. So when would this start? We piloted this project between 2008 and 2010, and then the SIPSN initiative was really launched in 2010 and has been going on since then. So we're into our 12th year of functioning. And how often are data extracted from the EMRs used by our primary care physicians? They're extracted now in the last, I'd say, 3 or 4 years, only twice a year, in December and June of every year. We used to have 4 extracts per year. It was downgraded to 2, mainly because of budgetary reasons, but also because we saw that there was not much change in the data, at 3-month intervals. So we feel that gathering the data twice a year and maintaining the data in a longitudinal database is really sufficient for the type of research that is done on the data. So how do we do this? EMRs in Quebec are privately owned. So in French, we say we have the fournisseurs. In Quebec, we think of TELUS, we think of Medphar, we think of Omnimed now as the 3 main companies who've more or less bought the other small companies that were in practice. So these EMR systems have their own data structure. So we needed, as a research database, we needed to develop different extractors to be able to question the specific EMRs from which we were collecting data. And so we've done this. I'll just close my phone. Sorry, I forgot to close my phone. And from there, we have our data managers. So there's 1 data manager per network, and there's a group of data managers at the national level. So they all work together to develop the different algorithms that allow us to first extract from the vendors, transform the data into the SIPSN format. Then we go into validation of the data, coding the data, cleaning it, getting all the unusual data entries, clean those out. And then we apply our algorithms to detect cases. And as you see, we have algorithms that have been validated to identify 13 chronic diseases, renal insufficiency, hypertension, diabetes, and pediatric diabetes, depression, COPD, zona or herpes zoster, or osteoarthrosis, dementia, Parkinson, epilepsy, dyslipidemia, and asthma. And there are other, I think we're up to 17 or 18 now, validated definitions that allow us to have, allow us to be quite confident that when we identify a case, that it's a real case. So we have positive predictive values and negative predictive values for these cases that are detected. And after that, this data is sent to the central database that is housed at the computer center at Queen's right now. And that allows us to provide information on the prevalence of the different diseases that I've mentioned, and also multimorbidity. And it allows us to also develop feedback reports to the different sentinels on their profile compared, as I said before, to other physicians in the database. But there's a second. This was the first way that we deal with the database, but the same information is sent to what I'll be presenting in a few minutes, called the data presentation tool, which is really an interface that we've made available to individual clinics so that they can further explore the data, the cleaned data in the SIPSN database. So I guess you'd like to know what type of information is extracted from the EMR every 6 months. So this is a French slide. I'm confident that most of you will be able to rapidly see what we're extracting. So we have, if the clinic is using a billing system that's within the EMR, we can have billing data. We extract data from active problem lists or reasons for consulting, the medication list, the prescripteur, certain laboratories, lab results. We don't take all the labs, but for right now, we have glycemia, hemoglobin Y1C, indicators of renal function, lipids, thyroid. I think those are the main ones that we're extracting right now. Family antécédent in English, how do we say antécédent? Family history, I'll say family history, personal health history. Those are the les champs, the areas of the EMR from which we extract the data. Requests for consultations. We don't have the reports of the consultations, but we have the requests for consultations. Physical in terms of patient height, weight, BMI, blood pressure, and intolerances, risk factors, smoking, overweight, exercise. So basically the regular risk factors that are indicated in the chart, and also vaccinations. So as you can see, it's a lot of information or potential information that's extracted. So just to give you an idea of the type of information that annually comes out of in our SIPSN report, this is an example of a graph with sex-specific and age-standardized prevalence of the validated chronic disease conditions in adults. So as you can see, the number of patients with SIPSN conditions was really high, about 35% of the people in the database. Dyslipidemia, depression, as I said, is quite high in terms of prevalence, but this is a lifetime prevalence. Overweight, hypertension, diabetes, arthritis or osteoarthrose, kidney disease, and dementia is quite low. Epilepsy and Parkinson are very low, and why we've chosen these conditions is basically because at one point we had some funding to look specifically at this type of neurologic diagnosis. Again, we can have an idea of the multimorbidity of the patients that are included in the database. And, 3 of these validated conditions were up to 20% of the 2 million patients in which we find concomitant, at least 3 of the validated conditions. And that excludes other conditions that people might have, but for which we do not have a validated definition. So in our Quebec data, this gives you an example. If someone wanted to do a study on hypertension in Quebec, well, there's, about 9,000 patients for which we have a hypertension diagnosis. Depression, about almost 10,000 patients in our database for which there was an indication of depression at one point in the chart. Dyslipidemia, the same thing. So in terms of numbers, it's quite interesting. In terms of representativity, for sure, as I said previously, these are academic family medicine teaching units. And basically, when we started SIPSN, we presented it as a chronic disease management, and there might have been a selection of patients in the database because of these criteria. So that might explain why we have these high numbers in certain disease types. So what are some of the research projects? that the Quebec arm has participated in the recent years. The Diabetes Action Canada study, and also more locally, a CIS de Laval study looking at a protocol for a trajectory for primary care follow-up of type 2 diabetes patients, in which we looked at pre-COVID, post-COVID COVID effect on the control of diabetes in these patients. That's how we used our SIPSN data. We're participating in SpiderNet, which is a pragmatic randomized control trial looking at a quality improvement intervention on deprescribing four potentially inappropriate medications in 65-year-old patients that are considered complex, that are taking 10 or more different medications. We've done a kind of a feasibility study to see that we could really apply Spider in Quebec. It proved, comment on dit, not successful, but conclusive. So we are now participating in the Pan-Canadian randomized trial. We're working on a PHAC-funded follow-up of DIADs, looking at patients with dementia and their caregivers, if they're followed in SIPSN clinics. So we're looking at the health of the caregiver and also of the dementia patient. So this is a longitudinal follow-up study that's cool. We're participating in 2 CIHR grants looking at the impacts of COVID, one on preventive care for young children. And so we're exploring the abécédaire and how we can extract from the abécédaire to see if there has been changes in the quality of the follow-up for these children before and after COVID. And this is conducted by people at Iman at Queen's and a person from McGill University, Patricia Lam. The Ripple project is also looking at impact of COVID-19 and chronic care management in primary care before and after COVID. And this is led by 2 researchers at McMaster. Dee Mangan is one of the co-PIs on this study. And Isabelle I think, is participating today. And we're participating to the Transilab Rosa study, looking at major neurocognitive disorders with the CIS de Laval. And we'll be using the CIS de Laval data around dementia to inform changes in the follow-up of these patients. So these are examples of research projects that are underway, to which our Quebec network is participating. I'd like to move on now very, very rapidly to the quality improvement function of SIPSN, the SIPSN database. So it's called the SIPSN DPT, the data presentation tool. And it's basically a tool, an interface that was developed for clinicians to look at the data of their own clinic. So this is the main dashboard. And in fact, some of you might have EMRs that provide good possibilities of analytics. I'm thinking in particular of the Mile Analytic. Maybe apart from the Miles Analytic tool, most other EMRs are not fortunate to have a powerful analytic tool that's provided by the EMR provider. So even with a lot of efforts, our agents de qualité are getting murky data from their queries. And they have no validation that they, for example, if they're looking to have build a registry of their diabetic patients, well, how will they make sure that they have all their diabetic patients if doctors are using DB, majuscule, minuscule, diabetes, full length, minuscule, majuscule, diabète insulinodépendant, non insulinodépendant, type 1, type 2. So it's very hard to get the full picture. And with the cleaned and standardized data to the Simpson schema, this tool provides clinicians and agent qualité with a search engine that allows them to be more confident that they have their whole clientele that they're looking for. So this is the dashboard. This is the main DPT dashboard. So very rapidly, this is a dashboard looking at the almost 47,500 patients in the Quebec network. So it gives us an idea of the average patient age in the network, and it's the yearly contact group, the number of patients who've been seen in the last, that are considered active, the average BMI for these patients, and the percent of patients in a rural area by their postal code. Then in terms of the sentinels, we see in terms of male and female sentinels, in terms of the sex of patients and the yearly contact group. Then we have a very easy graph giving us the percentages of the different chronic diseases that we have the validated diagnostic information for. Here we have the indice de vulnérabilité, le Pampolon. So in terms of quartiles, in terms of social and financial vulnerability. And here is a graph of the number of visits for people without Simpson conditions and compared to the patients in the database that have the chronic disease conditions. So this is the basic, I'll come back here a second. That's the basic dashboard that's used for CQ or clinicians that are interested. And you can see here that there are basically two functions. There's a research function that allows you to get access to answer different questions, and pre-formatted reports. So very rapidly, this is an easy interface in which you just click on the characteristics of the search you're looking for. Like if I want to have a patient that's been seen in the last 24 months that has had a diagnosis of diabetes, that is 45 years of age at the last extract. The type of, we're looking for hemoglobin A1C, we're looking for a smaller or equal to 7, and the latest lab report. So the clinician or AACQ enters the search in these dans ces champs areas, and they will get a report back at a few clicks. We also have a diabetes dashboard for patients within the database. So very easily we have the, in terms of the distribution in terms of age, the distance from the clinic, for my diabetic patients, the BMC, their height, their blood pressure measurements, and their weight. And all of these graphs allow us to be interactive and focus on certain areas if we wish. So again, here we have the number of medications on the left-hand side, and the comorbidities of these patients with diabetes. Well, that's quite useful. And again, then you can do some data mining, and for all of these patients, you can go and get the different labs that results that are in the charts. And in terms of pre-formatted one-click possibilities, if I'm looking for my diabetic patients, well, I will get my diabetic patients for which A1C was done in the last 2 years. I'll have the latest blood pressure taken in the last 2 years, and are these respecting the cible? Are the targets? Are we looking at what's the percentage of people within the targets? Same thing for the dyslipidemia. has the weight been checked? Has the waist circumference been measured, and is there a BMI in the chart? So it gives you a few of the indicators that we usually look at for a follow-up of diabetic patients. So I'll just finish here with inviting you to go on the website. We're revamping the website right now, but it will give you more information about SIPSN and the more than 100 publications that have been produced using SIPSN data from different researchers across Canada. And also looking at, we have a YouTube channel, and if you're interested in finding out more about the DPT, we have a few whiteboards in English and French explaining how to use the DPT. So these are all the persons with which we partner, and I will turn it over now for questions and discussion. So thank you for your patience.
Thank you so much, Dr. Lissier. So I guess we're open for questions. You can raise your hand or you can just write it in the chat.
Je vais peut-être commencer si, en attendant, là, j'en vois pas, mais première question. Merci beaucoup, Marie-Thérèse. Est-ce que, dans le fond, c'est extraordinaire comme source de données, puis on a parlé pendant ton absence que pour les résidents aussi, ça semble être une belle ressource. Est-ce que c'est assez accessible dans un délai rapide pour un résident qui voudrait faire un projet? Et est-ce que tu as expérimenté avec des résidents à date au Québec?
Alors, au Québec, non, mais je sais qu'au Canada, I'll say it in English. We'll revert to English. Better to answer in English.
Yes,
so the question was, for residents, there are residents within other PBRNs outside of Quebec who have used the SIPSN data. The SIPSN data that is available is always like 6 months previous to the, like right now, what's available is data that was taken in, I'd say December last year. We're still working on the last details for the June data for 2022. So, and the way it's done is there's our research committee that oversees the use of this data. So a request has to be put in, and it's a very easy one-pager summary of the research question, and the research committee looks at the feasibility and does the data within SIPSN allow to answer this question. And then the data cut is provided, and there is even a price tag. I think that for students right now, there are no costs to access the data. And so, yes, it is usable. And we'd be love to do it in Quebec for our small sample. So we have 2 residents in one of our clinics who've used it, but on a very, very small scale.
Thanks. I see Isabelle have a raised hand.
Yeah, thank you, Marie-Thérèse. It was really, really, really interesting. And I think it's a fantastic tool that can be used both for quality improvement, research, for physicians or nurse practitioners as well. But you answered my question was really about how to access this data. And I'm thinking of, doing clinical research for the different sites on different topics, even for medical students who would like to do a small project and describe a particular population. To have this really rich data from primary care is so important. So thank you so much, Marie-Thérèse.
You're very welcome. And, we're working right now in Quebec for our own cadre de gestion because of the new legislation now. And the cadre de gestion is being also prepared, a new cadre de gestion, because we're moving from surveillance to a repository of data, right? And we needed to have I don't know how you say in English, cadre de gestion, but, specifying how how this data is collected, how it's used, the privacy issues, security, etc., and how it's made available for research. So I think that for the SIPSN National, this will be ready, the new version will be ready in March. And we're working on our own Quebec cadre de gestion because we have to realign now with the new legislation, the one that's in discussion right now. So we're hoping that things will be easier for us in the future. And we'd really like to have McGill on board. As you saw in Ontario, there are very many different nodes. I think that it's just a question of opportunity that our Université de Montréal was chosen, 10 years ago. And now everyone has EMRs, and I think we should have pressure on Medfar to be able to include clinics that are using Miles, which is a very good EMR, and we'd really be happy. But I think we'll have to be more than one person indicating to Miles or Medfar that we want this. And then I didn't mention all the procedures that we have in place to inform patients that this is going on, and giving them the opportunity to say, I do not want to participate in SIPSN. So these are lots of details, but I'd be glad to answer any questions. Marion, I think, was the next one.
Yes, hi. Thank you so much for that interesting presentation. I missed a tiny bit because I just got to my chalet and there's like this little window where there's no reception, but I'm good now. Okay. The question I had was, if I understood correctly, you have to use very clear coding in order for SIPSN to be able to extract the data from the EMR. And I guess I'm wondering, in a family medicine teaching context, like the residents and students turn over with such rapidity, like how do you set it up so that people are using standardized data entry rather than writing, DM2 or all these different ways of writing diabetes?
It's all done, it's background. We're not asking anything to clinicians, in fact. We just take the dirty data and we superimpose a structure on it. So if there are 15 ways of describing diabetes type 2, well, we've validated the way we do it. So we'll take the 15 different ways and then we'll look at what the medications are. We'll have the lab results, the way it appears in the list of problems or diagnosis. We'll have the medications, and we might have consults. So we have all this, and if the person says yes, 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 okay, so this is a real case of diabetes. But there are many publications where groups have looked at how we can encourage our healthcare providers to be a little better at using ways of describing different diagnoses, and that's quality improvement. So we're just starting a project right now where we're looking at diabetes and hypertension on a very small scale and feeding back the information to doctors and saying, well, can you agree on where you're going to put the diagnosis and what words you're going to use? Or could you just click on the ICD code? But we leave that to the clinicians.
Okay, so I think I had misunderstood that it had to be coded a certain way to be extracted. Nope. So you're saying all the different terms are actually extracted. Okay, so exactly. That's great. And yeah. I was not aware, or if I was aware, it didn't stay retained in my brain, that Medfar had not agreed to participate. So I will definitely follow up with Alexandra as our research director, and we can look at, because 7 of our 9 GMFUs, I think, use Medfar, and some of the new ones also are going to be using it. So anyway, it's
and Marion, just for you to know that we had started the work with Medfar maybe 3 or 4 years ago, and in fact there were I don't remember the name of the IT person there, said there was maybe 1 or 2 days of work to finish it off. But then they said they didn't have the resources. Even if we had money, they didn't have the resources. And for sure, now it would be more than 2 days, but some of the work had been done. That's why we went through all the trouble of getting the ethics approval at the Jewish, at St. Mary's, but it kind of fell through.
I'm guessing that ethics approval doesn't last forever, that you have to probably go back through those processes. Yeah, okay.
Yes, yeah.
All right, okay. So definitely something to be looked into, because as Alexandra said, there's tremendous potential for this data, and it's super interesting for primary care.
Yep, thank you.
I believe the next person is Pierre.
Oui, bonjour Marie-Thérèse.
Oh, contente de te voir, Pierre.
C'est un plaisir. Là, c'est évidemment, nous, on a déjà utilisé avec Roland les données Simpson il y a quelques années, donc on connaît toute la valeur du travail qui est fait, de féliciter comme tout le monde, et surtout souligner la résilience et la persistance dont vous avez fait preuve ces 15 dernières années pour maintenir cette belle initiative et qui donne ses fruits. Maintenant, quand je vois les questions qui sont posées, je me dis waouh, voilà, on y est, ça y est, on voit les fruits.
Merci pour ton commentaire. Je vais faire un commentaire éditorial ici. Effectivement, c'est de la résilience et c'est peu de moyens, très, très peu de moyens, aucun soutien financier de la part d'organismes subventionnaires québécois, ni de l'unité soutien, parce qu'il y avait d'autres types de plateformes qui étaient en développement. Et c'est malgré les efforts que j'ai faits pour essayer d'aller chercher un financement et pour assurer un financement de cette base-là au Québec. Mon travail à moi, c'était de maintenir au minimum, puis d'essayer d'avoir des nouvelles cliniques. Et puis là, il y a eu la pandémie aussi, ce qui nous a tous impactés. Donc, là, on doit reprendre notre bâton de pèlerin, revoir chacune de nos cliniques, revoir le feedback, parce qu'il y a eu un hiatus, là, veut pas de l'extraction, mais de la collaboration avec les cliniciens, je dirais. Donc, mais je pense qu'avec l'arrivée de Aude, et je suis à la recherche de nouveaux cliniciens aussi, très jeunes, qui seraient prêts à prendre la relève.
On lâche pas.
Merci.
Merci à tous. Oh, English, sorry. So thank you so much. Thank you, everyone. Thank you, Dr. Lucier. It was very interesting. Just before we leave, I'd like to share the next research seminars activities that we have in our department. So the next one is on January 20th, and it's presented by Dr. Michelle Wolshinsky. And the next one after that is in February 24th by Dr. Natalia Ivankova. So hopefully we'll see you all there. Thank you so much for today, and see you soon.
Thank you. Merci, au revoir.
Parfait. So